So we'll move on to the next topic in the session. And from Jaipur, we go to London. And we have Dr. Aparna Hoskote from the Great Ormond Street. And she'll be talking to us about the low cardiac output syndrome in infants following TAPVC repair. Dr. Aparna, unmute yourself and put your video on. And welcome to this session.
Hello, my name is Aparna Hoskote. I'm a consultant in cardiac intensive care in Great Ormond Street Hospital for Children in London, UK. Today I'm going to talk about low cardiac output in TAPVC, total anomalous pulmonary venous connection. I have no disclosures. I am part of the Euro-ALSO Scientific Committee, and I'm also the section chair for cardiac ICU and mechanical circulatory support in the European Society of Pediatric and Neonatal Intensive Care. Whenever I talk about low cardiac output state, I'd like to emphasize the basics of cardiac critical care. It is important to know the anatomy and physiology, understand the surgery, understand the physiology in the immediate postoperative period, and it's very important that one must anticipate postoperative problems, identify them, and treat them promptly. TAPVC accounts for 0.7 to 1.5% of all defects, and the incidence is around 7 to 9 per 100,000 live births. It is characterized by pressure and volume overload of the right heart. So on an echo, you will find dilated right atrium and right ventricle, an obligatory right to left shunt across the ASD or the patent foramen ovale, which will maintain cardiac output. A small left atrium, a left ventricle that is squashed by the right ventricle, a flat interventricular septum, large pulmonary arterial system, and pulmonary hypertension. On an echo, you will find dilated types of supracardiac TAPVC depending on draining of the pulmonary venous confluence. In the supracardiac one, the pulmonary venous confluence drains into the brachiocephalic vein or the SVC, and it accounts for 50% of all TAPVC. The intracardiac one, the pulmonary venous confluence drains either into the right atrium or into the coronary sinus, and it accounts for 16%. The infracardiac one accounts for 15% of all cases. Here, the channel, the descending vein, goes below the diaphragm into the portal venous system. The most important pathophysiological question that one needs to ask is it obstructed or not? Now, as you can see, there are multiple different anatomical variants from intracardiac, supracardiac, infracardiac, and mixed. But the most important question is, how many of these are obstructed and where are the sites of obstruction? The sites of obstruction include the interatrial septum, or the anomalous venous channel, and there can be intrinsic narrowing within the walls of the anomalous vessel or an extrinsic pressure, anomalous pulmonary vein that is obstructed by the pulmonary artery and the bronchus, or there can be constriction of the draining vessel like the ductus venosus or the hepatic vein, and there can be any obstruction anywhere along the length of either the vertical ascending or the descending pathway. It's also important to remember that there are varying degrees of pulmonary venous obstruction. This is a typical snowman pattern of supracardiac TAPVC. Here you can see that the pulmonary venous confluence is draining via an ascending vein into the brachiocephalic vein and into the SVC. And this is what one typically describes a bronchopulmonary vice, where there can be obstruction of this pulmonary venous channel between the pulmonary artery and the bronchus. This is a still image of an echo of a baby with supracardiac TAPVC, a suprasternal short axis view where you can see the pulmonary venous channel is superior to the left atrium and is draining into the brachiocephalic vein. This is an intradiaphragmatic TAPVD, and you can see here that the pulmonary venous channel is draining into the portal venous system via the descending vein. Now here in this type of TAPVC, the chance of obstruction can be 95 to 100%. Again, an echo still image showing you a TAPVC, the infradiaphragmatic one, where the descending vein is draining into the portal vein and in the hepatic vein. Now, there are other types of TAPVCs, the intracardiac one, where the drainage can be into the right atrium or into the coronary sinus, or there can be mixed versions. The most common presentation is usually in a shocked state, with severe hypoxemia and poor hemodynamics. In addition, severe respiratory failure, the cyanosis, pulmonary congestion from pulmonary venous obstruction, and pulmonary hypertension. The treatment involves mechanical ventilation, such as positive pressure ventilation, and PEEP, and urgent surgery rather than ECMO. ECMO may be used to buy time until the baby can be taken to theatre for urgent surgery. Now, TAPVC is the only congenital heart disease that could be affected negatively by prostaglandin infusion, and this is due to the additional pulmonary blood flow through the duct. However, some right to left shunting that may occur through the duct may actually increase the QS, and the prostaglandin infusion may open or dilate the ductus venosus, which may partially decompress and obstructed infradiaphragmatic TAPVC. However, TAPVC must be looked for in any neonate with cardiorespiratory failure referred for ECMO. And it is very common to miss this diagnosis in a neonate with acute hypoxemic respiratory failure. So this is a case report of a severely obstructed TAPVC with residual connection to the left atrium, and highlights how the diagnosis of TAPVC can be very difficult. This was a baby referred for ECMO, and you can see that this was a diagnosis that was made on ECMO, and unfortunately this baby did not make it through and died, and the postmortem confirmed the diagnosis. This is an echo of a patient with TAPVC where you can see that the right atrium and the right ventricle are dilated, the left atrium and the left ventricle are small, and the pulmonary venous channel is here. You can see in this image that there is right to left shunting, the obligatory right to left shunting that maintains cardiac output. Infradiaphragmatic TAPVC, here an echo image showing you again the pulmonary venous confluence that is draining into the hepatic and the portal venous system. Now, when a diagnosis of infracardiac obstructed TAPVC is made, the corrective surgery should be performed as soon as possible. The long-term prognosis depends on pulmonary vascular bed at the time of surgery and the adequacy of the pulmonary venous and the left atrium anastomosis. A few comments on surgery. The repair involves an extensive atrial junction that is created with the pulmonary venous confluence into the left atrium. In the TAPVC that drains into the coronary sinus is unroofed and the orifice is made confluent with the atrial communication. Then the atrial communication is closed with a patch. In the infracardiac TAPVC, the extrapericardial common pulmonary venous trunk is often further from the posterior left atrial wall than expected. The anastomosis, therefore, can be vulnerable to obstruction. You can see that there is improvement here in this chest X-ray post-repair. Now, it's important to consider what has to be incorporated in a post-operative evaluation. It's important to establish pulmonary venous inflow to the left atrium. It's important to evaluate any venous obstruction, and it's important to assess the repair of the ASD. Is there any residual shunting? Is there any patch aneurysm? Look for obstruction at the pulmonary venous confluence and the left atrial junction and at the origin of the pulmonary veins. Signs of obstruction include a higher velocity, continuous disturbed flow, and a pulse Doppler signal showing peak velocities of more than 2 meters per second. Now, this is a paper published in 1974 where the postoperative mortality after TAPVC was 33%. Fortunately, with advances in perioperative management, we can see here that in the latest UK national data, the postoperative mortality is as low as 5 to 7%. Let's look at postoperative low cardiac output state and the specific causes of low cardiac output following repair for TAPVC. Now, pulmonary hypertension has to be kept in mind. The risk for pulmonary hypertension is higher if there is preoperative pulmonary venous obstruction. A small non-compliant left ventricle leads to high left atrial pressure, and that in turn leads to high pulmonary arterial pressure with reflex pulmonary arterial vasoconstriction, and this can cause RV failure, and an RV failure in turn can impact on the left ventricular function. In the situation where there is significant pulmonary hypertension in the immediate postoperative period, it is essential to rule out any residual postoperative venous obstruction. Let's look at physiology here and the interaction between lung volumes and pulmonary vascular resistance. This is a graph from a paper published by Wittenberger et al. In the Journal of Physiology in 1960. Here you can see that there is an important interaction between the pulmonary vascular resistance, and which is highest at the lower, and that is at the residual volume, and at the higher end at total lung capacity, and therefore ideal inflation pressures are at FRC to reduce the pulmonary vascular resistance. And this is because of the interplay between the alveolar vessels and the extra-alveolar vessels at residual volumes and at total lung capacity. Another important interaction which I'd like to highlight is the interaction between the pulmonary vascular resistance and pH. And again, this is a paper from 1966 which shows the pattern of pulmonary vascular resistance to changes of pH and PO2. You can see here that as the pH drops, the pulmonary vascular resistance increases. Now, how does one manage postoperative pulmonary hypertension? Important to use ventilatory strategies such as moderate hyperventilation, moderate alkalosis, adequate inspired oxygen, and normal lung volumes. Maintain an optimal hematocrit. Inotropes are required for right ventricular support, and use pulmonary vasodilators such as inhaled nitric oxide. Inhaled nitric oxide is a selective pulmonary vasodilator. There is no associated systemic vasodilatation, and it reduces the right ventricular afterload. However, it has to be used with caution in patients with severe LV dysfunction. And always remember that as you withdraw and stop nitric oxide, there may be rebound pulmonary hypertension, especially at low ppms. Respiratory insufficiency is common in the immediate postoperative period, especially if there is preoperative obstruction. Preoperative pulmonary congestion can be exacerbated further by bypass and therefore will need positive pressure ventilation for longer. And sometimes this can take a long time to settle and can persist for several days. The small non-compliant left ventricle has less effective stroke volume. And we know that in neonates, the cardiac output is more heart rate dependent. Furthermore, underfilling of the left ventricle is exacerbated in the presence of pulmonary hypertension and right ventricular dilatation. Often, the surgeons would leave the chest open, and there is elective delayed sternal closure in the case of preoperative obstruction. Inotropes are often needed. One has to use fluid replacement judiciously and avoid overfilling. And at times, atrial pacing may be needed to achieve the adequate heart rate for improving cardiac output. It's also important to remember that heart rate, preload, contractility, and afterload all contribute to cardiac output, which results in oxygen delivery, and oxygen delivery is closely interlinked with oxygen consumption, which is further influenced by basal metabolism, thermogenesis, and external work. Furthermore, hemoglobin and oxygen saturation and lung disease can further contribute to impairment of oxygen delivery. Do not forget the generic causes for low cardiac output state in the postoperative period. Is there bleeding? Is there hypovolemia? Is there increased afterload that may need to be managed? Minimize oxygen consumption. Ensure that the oxygen carrying capacity of blood is maintained, and help the lung by positive pressure ventilation. One can see sometimes arrhythmias, and the most common ones that are seen are supraventricular tachyarrhythmias and junctional ectopic tachycardia. In this paper by Hoffman et al., published in 2002, looking at the incidence of arrhythmias in a pediatric cardiac intensive care unit, the TAPVR repair was associated with junctional ectopic tachycardia and atrial arrhythmias, and 36% of patients had JET and 9% of patients had sustained SVT. Now, this is an ECG showing junctional ectopic tachycardia with AV dissociation. What is the management of JET? Supportive management. It's important to bring the temperature down. It's often called the warming up tachycardia. Keep the temperature in the normal range, and sometimes use systemic hypothermia to convert to sinus rhythm. One can give magnesium, amiodarone, and decrease the catecholamines. One may also need to use atrial pacing, particularly AV sequential pacing, when the heart rate is down. Treat electrolyte abnormalities, any metabolic acidosis, and correct hypovolemia. Postoperative ECMO is a bailout strategy if there is severe pulmonary hypertension, like a hypertensive crisis, or severe persistent arrhythmias. Again, high risk for postoperative problems in the situation where there is preoperative pulmonary venous obstruction. The goals of ECMO are myocardial recovery, control of arrhythmia, and control of pulmonary hypertension. Again, very important to rule out any hemodynamic issues, any residual lesions, and sometimes it may be necessary to do a cardiac catheter to understand if there are any residual problems. So finally, take-home messages for low cardiac output state in TAPVC. It's difficult to diagnose. Rule out TAPVC in neonate referred for ECMO. There's high chance of obstruction in an infracardiac TAPVC. If there is obstruction, emergency cardiac surgery is needed. Be careful with postoperative management of low cardiac output state and pulmonary hypertension. Look out for arrhythmias, and occasionally VA ECMO may be needed, and rule out any residual pulmonary venous obstruction. I thank you for listening to me, and I acknowledge the patients, families, colleagues, and staff at Great Ormond Street Hospital. If you have any questions, please email me at my email address here or post a message on my Twitter account. Thank you very much for listening to me. Thank you.
Thank you, Dr. Aparna. I know it must be very early in the morning for you there, and I hope you're safe in London. I'm sure you'll have a lot of questions on your email, and now that you have revealed your email ID and your Twitter account. And later in the course of this conference, we are also going to have an interesting session by Dr. Jagannath, who will be presenting a sort of collaborative data of the experience of TAPVC in India. And that should also be interesting to listen to in conjunction with your talk. So thank you very much for your participation.